Good morning, everyone. We're just going to give a few seconds for everyone to sort of get in here, but welcome to the first webinar of the Global Spine Surgery series of webinars that we have here. We're excited to have you all. Again, we'll just give us a few seconds for everyone to get in here. Okay. It's 8:01 and I'm going to be respectful of everyone's time. Again, welcome to the first of a number of sessions on the Global Spine Surgery series of webinars put on by the Harvard Global Orthopedic Collaborative and Sona Global. This session today is on failed back surgery syndrome. I'm excited to have you all. We know that you're joining us from all over the world. So thank you. Okay. So just a little background on our program and what we have going here. This has been a long time coming, but this year's session is on our spine surgery curriculum. The first session today is on failed back surgery syndrome. Next week is our early onset scoliosis session. Just so everyone knows, this is a case discussion, and on the Sona Global site, we have a lot of modules, and we encourage you guys to visit those beforehand because it just gives you a good primer for our discussion that we have. Just as a plug for next week, we have a few cases from all over the world, a case from Brazil, from Pakistan, from Ghana. And so it'll be a really great opportunity to hear what our colleagues from around the world are doing for management of early onset scoliosis. On May 16th, we'll have a session on interpreting advanced imaging in acute spine trauma. On the 23rd, we have another session on adolescent idiopathic scoliosis. Again, this is a case-based session. We have modules beforehand, and we encourage you guys those beforehand as well. We'll be closing out this year's seminar series on May 31st with our webinar on endoscopic spine surgery. Just beforehand, a few housekeeping items for using Zoom. First, if everyone can make sure to keep themselves muted aside from our presenters, that would be amazing. Secondly, I know everyone's tuning in from all over, and so to enable the show captions button, there's a small caret that you should see on your screen, and you can enable closed captions in the language of your choice if you hover over caption language. To engage in the conversation, please raise your hand. There's a raise hand screen. Alternatively, you can place questions in the chat. We'll try to field questions all at the end. But if anyone has any concerns, please feel free to chat us or raise your hand. A little bit more on the curriculum that we discussed beforehand. This is all available on the Sona Global website. This is an example of one of the complex lower extremity trauma series from earlier. And you're on each session, we have a number of videos and articles. We didn't have any for this one, but we have again some modules beforehand for next week's session as well as the other sessions we have. And we are also able to access all of our materials from the years prior by going on the Sona Global site. A little bit on our course objectives. Ultimately, we're hoping to improve everyone's knowledge of complex spine pathology and its management around the world. We hope to foster discussion and provide practical advice for surgeons, anesthesiologists, and physiatrists practicing in low resource limited settings. Our hope is, we're all coming in from different perspectives and treating patients in different contexts, and we hope to be able to channel all of this and exchange ideas so ultimately we can take care of patients in the most optimal way, no matter where we are around the world. Lastly, our hope is always to motivate and support the younger generation of providers coming up. Just a brief introduction of some of us here. Our esteemed course chair is Dr. Kiran Agarwal Harding. He is the founder. the Global Orthopedic Collaborative here at Harvard, as well as SONA. And he's a trauma attending here at the Beth Israel Deaconess Medical Center. He's incredible, and we're very grateful to have him here with us today. Our faculty discussant, one of our esteemed faculty from the Beth Israel Deaconess Medical Center, Dr. Jason Pittman. He's the chief of spine here, and we're very grateful that he's here giving us his insights. Thank you for joining us. My name is Zenaida. I'm one of the fourth year here at the Harvard Combined Orthopedic Residency Program. I will be pursuing a fellowship in spine surgery after residency, and I'm excited to be here and learn from you all. Thank you all for joining us. Lastly, we have an incredible group of people that have been instrumental in putting this together. Our HGOC and SONA organizing team, I mean, down to putting together the slides for this, reaching out to faculty, could not have done any of this without them. We're incredibly grateful uh, for all of the members of the team. Thank you all again. Again, the rest of the team here, thank you guys for your help and your assistance into creating this session. I'm going to briefly introduce our faculty presenters, and then we're just going to get started. Our first presenter is Dr. Anitha Krishnan. She's a retired orthopedic spine surgeon from the Emory University School of Medicine. She has an incredible wealth of knowledge in practicing spine surgery from the surgical perspective, obviously, in different resource-limited settings. And so we're very excited to hear her give us the primer today. We'll follow up with Dr. Catherine Mills. She's joining us from the PM&R perspective, and she will give us, again, that perspective. We're excited to have you, Dr. Lastly, I'm sorry, we have Dr. Krishna Shah. He's joining us from the interventional pain perspective from the Baylor College of Medicine. And he will give us his perspective on how exactly we're managing field back surgery syndrome. And we hope by the end of this meeting, we have a greater understanding from all of our faculty presenters and some questions in from the group as well. Okay, we're going to jump right in with Dr. Anitha Krishnan's lecture, unless anyone has any questions or concerns right now. Dr. Anitha Krishnan, you can go ahead and share your screen now.
Allow, well, okay, thanks. Now I think I'm going to be able to do it. Can you all see this?
Yes.
Okay, great. Thanks. Well, Zenaida, thanks so much for that introduction. I'm really very pleased to be here to talk to you about a surgeon's perspective, my perspective, but and also on failed back surgery, and also hear everyone else's perspectives, and hopefully have a very interesting discussion. Um, okay, here we go. So just to scope out this talk, it's really, this is more of a talk about diagnostics and diagnostic discipline that I think is so important for, particularly for spine surgeons. We want to do surgeries that are properly indicated, and this is the focus of of my talk through the lens of failed back surgeries. I think especially for people who are training and who are also in what we call resource limited settings. We think a lot about what we don't have, but what you do have is to the ability to really hone down on your diagnosis and try to avoid creating failed back surgery. In terms of a working definition of what failed back surgery is, We think of it as a persistent, recurrent pain after what's technically an anatomically successful spinal surgery. So the goal of whatever surgery, whatever the surgery was accomplished, and this was technically executed well. I have a real problem actually with this phrase. Obviously, once it was chosen, I wasn't going to push back on it, but I think that the phrase implies that the surgery itself did the failing, but really what mostly has led to where a patient is who's gotten this diagnosis is the decision pathway. So the diagnostic match between the patient and the operation. Sometimes it is the technical work in the operating room, sometimes not. In 2021, the syndrome was renamed persistent spinal pain syndrome, sort of take out the failed part of it and try not to assign blame. So I'm going to just call this FBSS in the interest of speaking. This is rarely a failure of the operation. It's more often a failure of the decision pathway that led to it, the diagnosis or a diagnosis that has been made by whomever labeled the patient at some point. And also, part of moving forward here is to try to distinguish these patients. Much of failed back surgery syndrome I'm going to talk about is preventing it. So the operation could, as I mentioned, might be perfectly executed. The question is the indication for it, and the matching up of the patient with their diagnosis and the treatment. And then I myself practiced complex spinal deformity for 20 years, and I had a myriad of patients who came to my office that were labeled FBSS, but they didn't actually have FBSS. What they did have was a really complex problem that whoever sent them wasn't able to solve. So we'll first talk about is operating on the wrong patient or the wrong pathology, which can create FBSS or over indicating an operation. And then I have a small case talking about missing the real diagnosis in a post-surgical patient. That can often be confounded because of other patient factors, and these are solvable problems. Could be solvable problems in the right hand. So certainly, as surgeons, it's really really important to try to distinguish these. Obviously, we don't want to fall into the first category, and we really want to try to, if we can, help a patient, point them in the right direction to the right person who can help them. And those are the patients in failure category 2. And just a little point at the bottom. So the surgeon who learns to avoid failure 1 is often the same surgeon who can recognize and rescue the patient in failure 2. So super important to match up, and this goes, obviously without saying for any patient anywhere, but for spine in particular, match up the symptoms, the exam, and the imaging. If they don't match up, stop. You should not operate, and you need to really do a better dive into what's going on. Here in the US, we have patients who have quite a bit of confounding factors, and this pops up quite a bit in spine in particular. Patients that have possibly maybe have other motivations for having surgery, such as workman's compensation cases. We have, unfortunately, very many patients who have opioid use and opioid dependence disorders. There are untreated psychological comorbidities, family and social stressors, nicotine dependence. Wherever you are practicing, you may have some of these or all of these or none of these or different factors, but these are very, very important to factor in addition, the resilience of the patient in particular, trying to make sure that whatever your prescription for the patient, that in the context of that patient and their life, that surgery is appropriate for them and that they are going to have every opportunity to be able to recover well from that surgery. And so that may mean switching from what you think maybe they're going to need a 3 or 4 level fusion, but you're going to do a 1 level laminectomy instead because they're not able to handle that, and or they have other things that are happening in their lives right now. The key is there to bring the patient into the decision as well and make sure that you can consider all factors. Just a point about MRIs, I'm sure all of us know this, but to reiterate, 30 to 40% of asymptomatic adults will have MRI findings on lumbar spine MRI. So common pitfalls of that I've seen with FBSS, certainly chasing disc bulges of unclear significance. So really operating on an MRI. I for I don't know how many neurosurgeons we have on the call, but I don't want to single you out so much, but we as orthopedists, I've seen so many patients who've had lumbar spine fusions, and when the driver is the pelvis, meaning often the hip or even the SI joint, and then over indication. So there's one level that's particularly problematic, but there's another level that doesn't look so great, and suddenly the patient is getting a two-level fusion instead of maybe a one-level lamidiscectomy, and then there's you can see the path that has happened with a patient. So trying to do this was always my motto. I want to try to do the least amount of surgery for each patient that will be able to address their symptoms and be able to be durable for them for some significant length of time. Will the patient's life be measurably better 6 months from now? You have to be able to answer yes to that question. I always have to ask the patient, what is it that you yourself are having a problem with? And is it reasonable that I will be able to get you back to whatever you want? Some older patients may say, I have to get off my walker or I have to be able to drive. And many times you won't really be able to offer that to them. So it's super, again, important to make sure your solution is in the context of the patient. Matching the operation to the pathology. We certainly see this even in well-trained physicians that who have done a lot of fusions, a lot of multi-level constructs, and they, especially right after fellowship, there's some training bias, but really, again, trying to do a limited amount of surgery for what the indication is. And this is a great example. The T2 sagittal MRI showing a pretty significant L4-5 disc herniation. But when you start looking at the disc at L5-S1, you can see that it's also, somewhat degenerated and a little bit further along in the degenerative cascade. And we certainly see patients. I feel like would be strange to all of a sudden have a second level thrown in here, but unfortunately, I have seen that. I'm sure Dr. Pittman has seen that, and all of you as surgeons have probably seen cases where there are someone decides that they have to throw L5-S1 into that, and who knows what can happen from that. In terms of you yourself as a surgeon trying to avoid creating FBSS, obviously you need to operate on the correct level, not excessive decompression, but adequate decompression. So really being very thorough about your preoperative planning, hardware placement, hemostasis, dural protection. All of these can lead to chronic issues, and then watching out for the over indication. So just a quick case. This is a 60-something year old woman who's a teacher who struggled with back pain and anterior thigh pain for many, many years. About 5 years or so, she had gone to see had gone to physical therapy, injections, and ended up in an outside surgeon's office with a pretty focal problem that was, in my opinion, over-indicated and poorly executed. She ended up having an over-indicated, somewhat poorly executed surgery. If you just to move back or maybe deep dive on why this happened, I think that maybe the scoliosis that the patient had was thought to be more problematic than it was. So she ended up, unfortunately, losing her job as a teacher. She ended up becoming dependent on opioids, went out on disability. She also had a lot of concomitant medical problems and some psychiatric history that had been well controlled with depression and anxiety, but this sort of spiraled out of control as well. She developed a fracture, she developed an infection. And this is how she presented to my office. I'll never forget the day that she was in my office because our whole clinic was derailed from her screaming and her histrionics, and this patient had already been passed around to two other complex deformity surgeons. No, sorry, not complex deformity surgeons, but two other degenerative surgeons. And then she ended up in my office demanding that I had to help her. And I think this is exactly the type of patient who can be pushed into that pushed into that FBSS bucket. She ended up having a frank non-union between two large two fusion areas, and required, unfortunately, quite a bit of surgery. She actually, if you look at that L4-5 cage, we did her anterior, and then we're supposed to do her posterior 2 days later, and she flipped out and decided that she had to leave. Because she just didn't think she could handle the second surgery. And so I had this woman, and I just could not convince her to stay. Walking around out there, I was waiting to hear whether this cage was going to cause a huge problem. And this patient in particular made her treatment extremely difficult. And unfortunately, many FBSS patients or many patients who fall into this category that we're talking about can be challenging patients. So, in terms of recognition after a surgery, like when we're taking a history, no matter what the distance is from the surgery, the timing of the problem is super important. So, no relief from day one, often the wrong diagnosis, maybe a wrong level or inadequate decompression. New pain immediately post-operatively should point us towards iatrogenic injuries. And then initial relief and then return could be a recurrent disc, advanced adjacent segment disease, pseudoarthrosis, hardware failure, or some epidural issues. So it's important to treat this label as a hypothesis, not a diagnosis. For me, some of the most rewarding cases of my career are patients that other surgeons gave up on, and that woman and I ended up becoming very, very close over the years. It's diagnostic excellence is what we're striving for. Whether you're seeing a patient before or after surgery, clean the slate. Try to, as much as you can, to bring an open mind to the patient that you are seeing. So it doesn't matter how thick the chart is, how many surgeries they've had, retake the history, go through all of it. It's difficult, but our patients deserve it. Re-examine the patient, question the diagnosis, and don't anchor on what you've been told. So I'm just going to wrap up now. Just the key takeaways, rigor and discipline. Certainly, we all want to approach our practices this way, treating the label as a hypothesis, and then just thinking about recognizing the challenging patient and rescuing the mislabeled one, and not trying and really honing on your practice to prevent FBSS in your own practice. Thanks so much.
Thank you so much, Dr. Anna. That was amazing. That was a great start. I guess my takeaway from this is it's very critical for indications to match the patient. Don't treat MRIs. Every patient is unique. And we want to do the least amount possible to help each patient feel better. Um,
Yeah.
I'll go for it.
No, I'll just say something really quickly. Like, I think we all want that. Like, nobody would say that they don't want that. I think even the surgeon that did that first surgery for her would have wanted that, right? I wouldn't think if, you asked him, he's like, oh, I'm gonna over operate, or I'm gonna do two level on everybody. The problem comes when you don't know the significance of this other, like on that one MRI I showed. And I didn't want this to be a huge case thing, because I think there's a lot to unpack here, and I'm interested to see what our other two presenters how they're going to frame it, because they are outside of the surgical specialty. But then it becomes challenging. Do I put this in there? Do I not put this in there? What do I put in? And that is, and some of it is that's the art of spine, but it's also the difficulty and the challenge of being a spine surgeon that we have to live with. Do we do too much? Do we do too little? So
I'm actually very curious, Dr. Pittman, because I know this is something that you talk about a lot, and I feel like we do a good job at the BI of thinking about patients and what they really need. I'd be curious to hear your perspective on all of this.
It, I think it's what makes surgery much more difficult than people believe. And clinic is actually the hardest part of what we do because it's where all the thinking and the problem solving and the planning happens. And it is, unfortunately, at least within the United States, where the pressure is more patients, less time. These patients take time, and you have to give them the opportunity to really push them to focus in on what hurts, what their main goal for your care is, so that you can tie that back to the picture.
Mm.
Again, if the picture and the patient don't match, you've got more digging to do, whether it be refer them to a neurologist for a different type of evaluation, EMG or nerve studies, or to your pain management partners who can do some diagnostic injections to kind of help narrow the field. And I hope that will tie in a little bit to what Catherine and Krishna have to say about their in uh, a challenging situation, and it is that balance between doing too much and too little. And I've often found myself on the side of doing too little and kicking myself a little bit, and then I kind of rebound a little bit from that, and the pendulum slings a little bit towards doing maybe a little too much. So yeah.
Yeah. Oh, Dr. Anantha Krishnan, please. I
yeah,
see
just
that.
one quick comment about that. I think for me as a deformity surgeon, it was a big joke with my partners that, if you give me like a case that needs a T4 to the ilium, yeah, I'm good. But I'm trying to decide between 1 or 2 level fusion. I'm like racked with guilt or, with indecision, sometimes almost right up to the day of the surgery, right? Because it's just like, what am I doing for this patient? And so it's like, and they're like, don't do a T10 at the pelvis. I'm like, all right, I'm not going to do a T10 at the pelvis. It's not on the menu. But I think that degenerative spine is one of the most cognitively challenging position cases for us. And it behooves us and for the patient and their lives and their goals. I often would do the same thing. I felt like I could get away with a laminectomy and for X time, bring that patient into the decision, understand that, I think you might get to this point, and, make sure the other thing is make sure that they are, you give them whether it's 5 exercises to do every day for them to, do their nerve flossing, do their and try to give them other things other than just surgery to keep some control over where they're going in life because you might not see them, after you're not going to see a laminectomy and they're going to go away, but they've got some residual pain here and there, and so bringing your other disciplines in outside of surgery.
Fascinating discussion. For the purpose of the time, maybe that's a great transition to our next speaker. But before we do that, Dira, I also wanted to maybe have you say a few words about the low resource setting and how, like now, more and more spine surgery is becoming available, and you'll have, some of our colleagues will have clinics with 150 patients,
Yeah.
all looking for something, right?
Yeah.
And people of varying levels of training who are starting to do spine surgery. So if you could just frame a little bit for our, viewers who are all around the world about your experience in that perspective and the role of failed back surgery, maybe while Catherine gets her slides up and running, that would be great.
Yeah, sure. I think that's super important. I don't honestly, I think the principles are going to be the same. I'll tell you what I think is can be distracting is that when I've operated in low resource settings and the people that I know who are in those settings, we're thinking a lot about what we don't have. We're thinking a lot about I don't have implants or I only have this number of implants or like the focus is really around so much in your thought is around the instruments and the implants that we don't sometimes the patient, we're not as much maybe thinking about the patient. And I know many times when I've been, are you guys still there? You still, yeah, I haven't cut out. I've been in situations where I'm like, you know what, I'm going to just do a laminectomy on this, and people are like, oh, we think I would only do a laminectomy on this just because you're here, right? I'm like, no, this is what I would do over. In the US also. And so really trying to say, hey, this is what I would do for this patient, regardless of where they are, right? And trying to bring that mentality to each patient, I think is really, really important. And then I think the other challenge in LMICs is the follow-up. And I mean, we have that challenge here in the US also. So you want to make something that's durable in case the patient isn't going to be able to come back to see you and will be able to be handled by somebody else. And so that may mean just like less fusions. I think we need less fusions overall, but so trying to stay away from the fusion mentality as much as you can and really focus on what we just talked about, the diagnosis, doing the right thing for the patient in their context.
That's very insightful. On that, we'll transition to Dr. Mills and hear from the physiatric approach.
Oh, great. Thanks so much for having me. Can you see my slides or can you see my presenter view?
Yes, you're all
Slides.
set.
Great, thanks. So I entitled my piece of the talk today, Failed Back Surgery Syndrome, which I did see the corrected name when I was doing my like research and looking up some new papers. A physiatric approach to evaluation and treatment, and just a quick background on what physiatry is. It's also called physical medicine and rehabilitation. Um, and it's a field of medicine that's really focused on function and quality of life. And so I think it ties in really well with persistent spinal pain syndrome, failed back surgery syndrome, because we're focusing on like how do we get people back to doing what they want to be doing despite whatever disability or impairments they may have. Um, so I have no disclosures. So failed back surgery syndrome. I'm going to go over this really quickly because I feel like we already went over this really well in the last section of our talk. But it's recurrent pain after spinal surgery. It can have radicular features. It doesn't have to. It's super heterogeneous with a lot of potential causes that were already reviewed. But briefly, like structural, which could be recurrent disc, recurrent stenosis, adjacent segment disease, a failure to resolve the underlying issue, whether that's like not lining up the patient with the right surgery because of a misdiagnosis, scar tissue, nerve injury during surgery, infection, operating on the wrong person again is a big thing that I think does happen. Not necessarily that the surgery was technically not done well, but that the patient was not the right patient for said surgery. And the prevalence is, because it's such a heterogeneous condition, hard to know the true prevalence, but it's estimated between 10 and 40% of people who have surgery. I will move on from that. So, in terms of clinical evaluation, we want to be really cautious with the evaluation and really pay attention. And I really liked the point of making sure that we take a careful history, we clean the slate. It doesn't matter how many people they've seen before, get the history yourself because things can be wrong in the chart. Things could be misinterpreted and written down. And then if we're just going based off of what other people say, we may not understand what's really the big complaint. So understanding what the pre-surgery pain was and then what they're currently experiencing. Is it the same? Is it different? Classifying the phenotype of pain. So is it axial pain or is it radicular pain? Is it neuropathic? So that shooting, burning, tingling pain, or is it more nociceptive pain, that dull, aching, throbbing, sharp stabbing pain? Do they have a component of myofascial pain that's causing referral patterns? Is there central sensitization? Remember, chronic pain can change our brain chemistry. And then we have this like cycle where the pain is, perceived and experienced in a much more severe way than what we would expect based off of the pathology. Certainly looking for any red flag symptoms that would require more specific, more in-depth workup with specific types of imaging. So if there's a history of cancer, a recent trauma that's after surgery, unexplained weight loss, night pain, systemic symptoms, fever, chill, sweats, all of those things are concerned for cancer. A history of IV drug use can be concerning for an epidural infection. Systemic steroid use can decrease bone density, cause a new compression fracture. So trying to identify big things that could be going on is really important. Identify the functional limitations. What is it that the patient can't do that they'd like to be doing? What about their pain is stopping them? And asking them their goals. I think that's something that was really actually a good point made in the previous talk is like find out what the patient is wanting from you. And what they are expecting, because a big thing with failed back surgery syndrome is sort of a mismatch of the expectations of the outcome of surgery. A lot of patients will come in and they say, I want to be pain-free. And some of my patients probably hate me for this, but I often say pain-free is a myth. Like we can get you better, feeling better, but the idea that you'll never have pain ever again is really unrealistic. And I try to set that expectation going into things because I don't want people to be disappointed and chasing something that just doesn't really exist. One of my pain management colleagues that I work with frequently will tell his patients that pain is a sign you're still alive. I haven't gotten to that point yet of saying that because I think that I will get laughed out of the room as a short, younger female physician saying that, but he's older than I am and male, and so that gets laughed at less, I think. Much to my own chagrin. So the physical examination, a physical examination that is thorough is vital to understand what's going on. Every exam should include an observation of gait because there are different signs in gait that can implicate what is going on. Palpation, checking range of motion, a careful neuro exam, and then special maneuvers. And I can't stress this enough because I see it all the time where hip pain is mistaken for radicular pain. Every spine exam should include a thorough hip exam, please, please, please. There's tons of overlap in the referral patterns of the hip and the spine, and it's misdiagnosed so commonly. And then maneuvers, so trying to use special maneuvers to elicit what type of pain someone's having. So facet-mediated pain can be elicited with KEMS or facet loading, so that extension with rotation. Radicular features can be elicited with a seated slump test, a straight leg raise, femoral stretch test for more the upper lumbar nerves. SI joint pain is really common and very common after like a lumbar fusion because the SI joints then take on more stress and get irritated. So thigh thrust is a really good one. That's where patients on their back, knee is flexed to 90 degrees, hips flexed to 90 degrees, and you put a shear force down through the femur into the hip joint, essentially. Back pain or buttock pain that's reproduced with that can be SI joint pain. SI distraction, so pressure on the ASIS, separating them apart, can elicit pain from the SI joints. SI joint compression, where the patient's laying on their side, affected side up, you put pressure on the iliac crest. If that reproduces pain over the like SI joint region, so upper buttock on lower back region, sacral thrust is pushing onto the sacrum directly while the patient's prone. Faber, which is the figure 4 test, and Ganslin's is a test where you have the patient on the edge of the table and you bring the leg that's still on the table up towards their chest, knee to the chest, and then push the thigh down off of the table, and that elicits back pain. Intra-articular hip, so range of motion. If the range of motion is limited, if it's painful, Stinchfield is resisted straight leg raise, just slightly off of the table. Log roll and the Fader test, so flexion, adduction, and internal rotation, all of those can identify intra-articular hip pain. So is it radiculopathy or is it facet pain? So on the left side of the screen, we have the dermatomes, and then on the right side of the screen, we have some referral patterns for the facet joints. And often it sticks to the low back and the buttocks, but it can radiate down the back of the legs. It can go into the groin and the front of the thighs. So keeping that in mind as you do your exam, not everything that goes down the leg is a pinched nerve. SI joint pains, is it radiculopathy or is it the SI joint? SI joint most commonly will stay in the buttock region, but it can radiate down the back of the thigh. It can go towards the knee, and it can present into this area here of the posterior lateral thigh, calf as well. And is it radiculopathy or is it hip pain? This picture on the right side of the screen is one of my favorite things to share with my patients when I'm trying to convince them that it's not a pinched nerve in their back, it's their hip joint. It's a study by Lesher from 2008. They injected chemical irritant into people's hips and had them map where the pain is. It looks remarkably like a radiculopathy in some cases. So something to keep in mind. Imaging wise, sorry, I know I'm going fast. I just want to make sure I get everything in. So X-ray of the lumbar spine, X-ray of the hips can be really useful. If you need an MRI of the lumbar spine, if somebody has already had spine surgery, you want to do it with and without contrast if you can. I know we're talking about low resource settings at times. And so if you can do it with and without contrast, great. That helps identify scar tissue. And you can look for recurrent stenosis, incomplete decompression, or recurrent disc herniation. And then CT can be helpful as well. In terms of management, I'm going to try to do this quickly because I don't want to run out of time. But a mainstay is going to be rehab. Interdisciplinary rehab with PT, OT, and cognitive behavioral therapy can be really helpful for people with chronic pain. If you don't have access to all of those, certainly like looking for exercises to provide your patient with to focus on core strength, mobility, stability, especially hip stability and pelvic stability can be really helpful. If you have access to cognitive behavioral therapy, that's very helpful for people with chronic pain. And always to remember that success is measured by more than just pain. If we keep the focus on only pain reduction, a lot of times we're going to have a hard time helping our patients with failed back surgery syndrome or with chronic pain to manage. We want to focus on function and return to activity, even if there is still a component of pain there. Medication wise, there are tons of medications that we can use. I don't do a lot of medication management, to be completely honest. I do a lot of procedures to manage pain. Mostly I use non-steroidal anti-inflammatories, but there are lots of options there. Tylenol can be really helpful additive to an anti-inflammatory or any of our other medications. Anticonvulsants for neuropathic pain like gabapentin and pregabalin can be useful. You want to be careful in kidney disease though. There's renal dosing for both of those medications. Antidepressants that have pain control effects are duloxetine and then the tricyclic antidepressants, though again, especially with the tricyclics, there's lots of side effects to keep in mind. Muscle relaxers are useful. They're not my favorite because a lot of them cause sedation, but they can be helpful in people who have neuropathic pain. And then I don't prescribe low dose naltrexone, but some of my pain management colleagues do. But again, only if they're not on opioids. If they're on opioids, you're going to really upset your patient. And then in terms of more invasive interventions for pain management, epidural steroid injections can be both therapeutic and diagnostic. All of these procedures can be both therapeutic and diagnostic, multiple approaches to epidurals. And I think that Dr. Shaw, I think, is going to go over this in more detail. So I'm going to skim over this. Facet injections, medial branch block to radiofrequency ablation can be really helpful. Sacroiliac joint steroid injections can be diagnostic. A hip joint steroid injection can be diagnostic. If your patient's radicular pain goes away with a hip joint injection, you know it's not coming out of the back, which happens to me very frequently. And then greater trochanteric bursa corticosteroid injections can be helpful if they're having pain radiating down the lateral aspect of the thigh to identify if that's coming from that bursa and an IT band syndrome or if it's coming from the lumbar spine. Why does this matter? So it matters because low back pain is a leading cause of disability throughout the world. And again, 10 to 40% of patients who have undergone spine surgery can experience persistent pain after surgery. And it has a significant impact on people's physical health. They're not able to be as active, and that can cause detriments to physical health. It impacts mental health, increases healthcare utilization and cost, and contributes to disability. And the success rate with spinal surgery can diminish with each subsequent surgery. So we want to carefully select the people who we really do believe will benefit from surgery to move on to have a second surgery. I don't think I have any time to go over cases, but if at the end of everything we do, I have a couple of interesting cases that I can bring up. Um, but I think I'm already 3 minutes over.
No, that's great. I think that's a great
Sorry, that was fast.
no, that was amazing. Thank you for sharing. Um, I guess my question is that was very inclusive. Thank you. What's your interaction with spine surgeons when you're looking at these patients? How do you sort of create the framework for the plan and with the surgeons that are sending these patients to you?
I do a lot of, I mean, Dr. Pittman and I have shared plenty of patients at this point. And one of the cases I was going to bring up was a shared patient that he probably would remember. But I communicate back and forth a lot. When I have someone sent to me by a surgeon, I often will like send them a note about what I thought on exam, and what my thoughts are about what to do next, what intervention I may do. And then also like when I'm sending someone to surgery, I often will share more information than anybody really cares to know in my message when I'm sending a request for a consult. But I always want to make sure that I'm making it really clear why I'm asking for a consult or why I think what I'm thinking. And I felt pretty validated. And with the little conversation between talks before about how long these patients take, because I run behind a clinic all the time because I'm trying to really understand what's going on. Um, and then I always want to make sure that we are clearly communicating and have that line of communication open because I think that's really helpful because you just have to communicate and have a team approach. And the last slide of my talk of how we had gotten there was that interdisciplinary care is the best care for our patients. So everybody should be involved and everybody should be in communication when you're sharing patients.
Well, Catherine, if we have a few moments at the end, maybe we could get to that case. But I do want to
Sure.
give Krishna a chance to
Yeah,
talk too, because
definitely.
he represents the third piece of all of this, which I'm really excited to hear. Krishna, if you don't mind, please go ahead.
Yeah, absolutely. Thank you, everybody, for being here this morning, and thanks for having me. So I'm going to discuss interventional considerations for failed back surgery. I have no disclosures as it relates to this topic. So I just want to discuss a few definitions so we're all sort of on the same page when it comes to really understanding the pain in a surgical spine patient. I work in a spine center. We have 3 or 4 spine surgeons and 2 or 3 people like myself who are non-surgeons, but we do a lot of interventions. And so understanding the pain is super important. So somatic pain to really originate from the skin, muscles, bones, and joints. That's like if you cut yourself, that's somatic pain that you're having. Visceral pain is coming from the organs. It's more diffuse. A neuropathic pain. This is what I'm going to be really talking a lot about. So neuropathic pain is caused by a lesion or disease in our nervous system. And then there's inflammatory pain, which is a hypersensitivity that occurs from tissue injury. And that does trigger some immune response that we have. So failed back surgery, this was talked in length the last 2 speakers. So it's really the most common definition. I think Dr. A mentioned this earlier. It's persistent or recurrent pain after anatomically successful spine surgery. There's no correctable surgical target. The dominant pain phenotype is really neuropathic pain. And so this is really driven by central sensitization, there's neuroinflammation, and glial activation that I'll talk about soon. But the key driving factor here is that it's neuropathic pain. Again, no correctable surgical target, and they have this diffuse symptoms. The prevalence is around 20%. A great study in 2018 to sort of discuss that from all lumbar spine surgery. And when conservative therapy does fail, we look at neuromodulation, especially spinal cord stimulation, as a option, and that's what the most of my talk will be today. So why do we use spinal cord stimulation? It delivers a targeted electrical stimulation to the dorsal column of the spine that sort of modulates pain transmission. How does spinal cord stimulation work? it's still we're still learning sort of the clear mechanism, but there's three main thoughts: is A, beta fiber activation, GABA release, and then our wide dynamic cell inhibition. There's different types of stimulation that I'll get into. There's the high level is tonic, high frequency burst, and DRG. And I'll briefly talk about one of our landmark studies, the process randomized control trial by Kumar in 2007, that discussed um, conventional medical management versus SCS and failed back surgery. So mechanism, we're looking at the gate control theory. That's a beta fiber inhibition um, for calling inhibition within the spine. Other mechanisms of actions, we're looking at wide dynamic range neurons in the dorsal horn. So these cells particularly become hyperexcitable. And so this is driven by glutamate release and central sensitization. So this is why patients experience this pain in failed back surgery. So what does spinal cord stimulation do? It induces a GABA release. It suppresses these hyperexcitable neurons and leads to inhibition within the spinal canal or the dorsal horn. And that's sort of the key driver and why spinal cord stimulation works in this patient population. So what is a spinal cord stimulator? There's two phases in this. There's a spinal cord stimulator trial. You place catheters within the spine for 7 days, and you sort of determine the effectiveness of it. Patients maintain their normal activity, and we sort of reprogram them on a daily basis to determine how effective this device is. If it is successful, we're able to implant them surgically into patients. Very high level programming basics. When we're talking about programming, we're looking at the amplitude, pulse width, and frequency, and we are changing these individually to determine the appropriate effectiveness, again, within the spinal canal. Different waveforms that we briefly talked about. This is just different ways that you can provide stimulation to the patient. The most common type of stimulation is conventional, which is a tonic. And what that is that patients having this device inside of them, it produces a very comfortable paresthesia, like a vibration sensation or like a TENS unit at very low frequency. And really the big con is that this constant vibration can feel uncomfortable to patients. So our landmark study is our Kumar 2007 process study. We compared spinal cord stimulation to conventional medical management, which is medications, nerve blocks, and physical therapy. We looked at 100 patients of failed back surgery that were randomized, and we looked at outcomes at 6 months and 24 months. And so what we found in this graph here, you can see that pain scores were significantly less at every follow-up. And so 42 patients, not only did they find an improvement in pain, we found an improvement in quality of life and functional capacity compared to conventional medical management. So take-home points here is failed back surgery, from my perspective, is predominantly neuropathic. That can have neuromodulation, spinal cord stimulation as an option. Again, there's no structural abnormality. It's really trying to understand what symptom they have to sort of treat that. Spinal cord stimulation does have level of evidence for failed back surgery. We discussed that process study, and there's several different waveforms and options that we have to treat these patients. So SCS is cost effective. It reduces opioid use, improves function, and really does help sort of a long-term healthcare utilization. I apologize for running through that very quickly. I was trying to be respectful of everyone's time. Thank you, everybody.
Thank you so much, Dr. Shah. That was great. Especially intriguing in the use of um, the stimulators. And I'm just curious, doctor, from the surgical perspective, how you are seeing patients, like how, if you're able to see patients where we use stimulators and how they're doing in clinic. I guess from your perspective, Dr. Shah, and also from Dr. Pittman and Dr. Anantha-Krishnan.
Yeah, I mean, I'll start. We within our spine center, we have, obviously we only do spine. And so Um, Really evaluating the first aspect is understanding what pain they actually have.
Yeah,
If there is if they have adjacent segment disease, if they have um, degenerative changes, axial back pain, that's not all these things are not neuropathic. SCS is just not going to help them. So it's really
yeah,
not structural target. Oftentimes, as you know, we see patients who have a fusion and then 5, 7 years later they develop adjacent segment disease, but they have comorbidities that they may not be an ideal surgical candidate. I still would not do stimulation on these patients because they're the structural abnormality. So the pain source is different. So really understanding their symptoms, really, like Dr. A said, symptoms exam and imaging is super, super important to understand their pain type and then understand what interventions or surgical options you can provide to them.
totally.
I think it's important because we've kind of looked at the neuropathic side of this and where you classify failed back surgery gets back to this look for what the patient is truly looking to have improve. Because if somebody comes into my office, I've had 3 surgeries, I feel XYZ, it's important to ask, well, what were the symptoms that led you to have those first surgeries? What was it you were hoping those surgeries would help you with? And they'll often go, well, I've had horrible back pain. As surgeons, we are awful at back pain. And it's really key to hone in on that when you talk to your patients. Radicular pain, nerve pain, claudication, we can do that all day and do it predictably. But we sometimes still don't succeed in that patient population, whether it be an iatrogenic issue, a post-operative issue, or the hard part for patients to understand is they are going to continue to age around whatever it is we do. We're addressing the problem that is in front of us right at that time. And so that's, I think, really key to this is getting to the heart of why the patient's there. And only then can you begin to understand their thinking and be able to align, like Dr. A said, align the expectation. I think it was Catherine, align the expectations with what we can offer.
Certainly. And I know, we're talking about all of these things very much in our context, and we have the privilege of having so much amazing, like just interdisciplinary conversations from the PM&R perspective, from the interventional perspectives. And, I know for our colleagues that are in settings that don't have all of these resources, it can be a challenge managing these patients. And I'd be curious again you guys' perspectives or any questions that anyone else or scenarios that anyone else has from the Zoom world about their experience with these in low resource settings.
Yeah, Zenaida, I think just for the purposes of time, maybe we should have the closing thoughts from all of our faculty, sort of on like last teaching messages for our Zoom audience. Catherine, I'm so sorry we didn't get to your case. I
That's
really hope that we
okay.
can't, like maybe we can record it and we can post it online for folks to see, because I would
Sure.
love to have that. That would
Yeah.
be really great. Yeah, but
Yeah.
maybe Catherine, we can start with you on sort of your closing thoughts. And from you, I would really like to understand, especially for our colleagues around the world, like how do we build a team that includes colleagues with your skill set, with Jason and Dheera and Krishna's skill set, bring them all together to effectively diagnose and prevent failed back surgery syndrome, and then manage it down the line when you're already, maybe seeing a patient who's referred from another center. Would love to
Yeah.
hear your thoughts on that.
So I think my closing point would just be making sure you take that history and do a very thorough exam because we don't want to operate on people that don't need to be operated on. And one of the two cases that I was thinking about talking about is a guy who has horrible spinal disease on MRI, and everybody else is telling him he needs spine surgery, not a hip replacement, but his pain went completely away with a hip injection. And so keeping in mind that things outside of the spine can cause similar features, I think is really important. So that's my takeaway. In terms of building a team, I think it's hard because you have to find the people. But I think mutual respect for the different fields of medicine is really important to build that team. And like I came into BI and like Dr. Pittman welcomed me with open arms and like respects my opinion. I at least I think. Uh, and like like feeling like I can say, "Hey, look, I like you sent this person to me. I did this thing. This is what's going on, and I think they don't need surgery, or I think that you really maybe they do need surgery again." And like having that comfort level with your colleagues and that mutual respect and like being open to like I'm always open to when somebody tells me I'm wrong, and like I think at least my relationship with Dr. Pittman and Dr. Gandhi and is that like if I think that what they've told me about someone is like not the right thing, I feel like I can tell them that. And I think like that having that respect is really important and respecting the different fields of medicine and the different opinions and not being offended when the person who you send someone to for that second evaluation or that second opinion or second set of eyes or fifth set of eyes, right? Like not being upset if they have a different idea than you do.
Krishna, could we hear your thoughts on that one too?
Yeah, yeah, definitely. And my big take home point, I've been practicing for 8 years now, as faculty, and I feel like I've continued to learn about the spine, and I learn it every day. Less is more when you're looking at the spine. So really think about understanding their symptoms, their exam, their imaging, and understand that less is more. Whether it's interventions or surgery, patients can do very well if you keep that mantra.
Dira, do you have any closing thoughts?
Yeah, I mean, I really like the less is more, and I do think that all of us who are on faculty here have had the benefit of learning from others, especially surgeons. I think that it goes both ways, right? Surgeons, I learned so much from my non-op partners, and I don't think that unfortunately, like most low resource settings, you'll have that advantage. But if you can find somebody, consult someone, be able to discuss the case and really seek others' opinions. I think it'll round things out, and you'll learn a lot, and the patients will do better as well.
Dira, maybe you can give a few seconds to this question that was just posted by Mustafa in the comments. In low resource setting, it's very difficult to convince people to have a second surgery, right? I mean, we've heard from two speakers who aren't surgeons here about the myriad of different options that exist outside of surgery. But if you've worked in these settings, how do you convince a patient that perhaps surgery is the right move, or not the right move?
Yeah, I mean, I know I'm sure Dr. Pittman knows too. Like I spent a lot of my days in the US at Emory operating on or trying not to operate on patients. It would be a little bit exhausting. Sometimes you can see how patients will end up in a situation where they just get a surgery because it takes more time. It takes yeah, just takes more time. But I think, there's a reason that the patient comes back to you after they've had a surgery. And what Jason had mentioned was so on point, right? You have to go back and ask them, why did you try to go back? Why did you have that first surgery? And if they're there, you owe it to yourself to see if you can help them. And if that does entail another surgery, most of the time they should be open enough because they're in your office, right? It's an elective thing, right? If it's not an elective thing, it's completely different. But I do think that if you have the ability to help them, you should. I remember some of my worst days were when I thought, oh man, I can help this guy. Damn it, I can help this guy, right? And because I'm thinking about all of the stuff that's going to go into helping him, but I know that I can help him. But if you can't, then you have to just be able to say, I can't help you. I think it also behooves us as surgeons, especially in low resource settings, to learn about other techniques, and be able to also provide like, okay, I'm going to send you for these exercises. I'm going to give you these exercises, or take a little bit of ownership outside of our space. So that's it.
I really liked the way that Krishna talked about different types of pain and also how Catherine talked about a diagnostic workup that's both diagnostic and therapeutic, like the injections, right? Like seeing a patient and placing an injection, and that maybe helping with decision making about which levels to fuse, what to attack with the surgery. Jason, any final thoughts on this before we maybe close things out?
I'm going to follow up on what you just said. And the majority of injections are performed under fluoro. And even in a low resource setting, often C-arm is a resource you do have access to. And don't think the courses teaching injections are just for physiatry. You can do so much for your patient if you don't have access to a physiatry colleague, a pain management colleague, if you'll invest a little bit of your time and go learn to do the injections yourself. Because that will often give you the tool to convince the patient of the second surgery because you did an injection that took away their pain, which allows you to target that surgery. Or you did the injection that helped that patient feel better. While it may not get you a surgery, it's giving you yet another tool in your toolbox that lets you be a spine doctor. And I think that's a great opportunity. And I know AO teaches courses, NASS teaches courses in injections. I'm sure there are multiple other international organizations that have injection courses, but don't think those courses are just for the physiatrists.
Maybe there's a need for us to organize such a conference somewhere in a resource limited setting. That would be great. Well, thank you all. Zenaida, maybe let me hand it over to you for final closing thoughts and ending our final slides here. I think we're 5 minutes over, but I think this is a fascinating discussion. Thank you all.
No, that was great. Everyone, Dr. Pittman as a trainee, that's definitely something that's helpful for me right now. So I will be thoughtful about seeking those opportunities, especially as I move forward. But thank you all for sharing all your perspectives. Thank you all for joining us from the audience so far away, near and far. We're looking forward to next week's session. And again, if you guys have any questions, feel free to reach out afterwards. But we're going to close it out and we'll see you all next week, hopefully.
Thanks, Zenaida. Can you just pull up the last slides that show the QR codes and stuff like that?
Yes.
Yeah. Just want to put a final shout out to everybody that if you attend these live sessions and you complete our post-session surveys, we'll be able to give you a certificate of participation for the full conference as a whole. So please do that. Everything is on Sona Global Academy. If you enjoyed this session, please encourage your colleagues to join as well. Everything is free. Everything will be available, including the recording of this session will be posted onto Sona Global Academy as well. So please join us in this journey. Next slide, please, Zenaida. Yeah, here's the link to Sona Global Academy. We can put that also in the chat.
I'll put that in the chat for you all.
Thank you. And then next slide, Zenaida. Yeah, and then we can just close out with this slide and just leave this up for a little bit. People can scan that QR code to get the post-session survey. And any questions or comments, we always want to make these sessions useful to all of you. This topic was proposed by members of our global community, and we heard the request. We put this together specifically for that. So please know that we're listening to the comments that you share. Please stay with us. Thanks so much, everybody.
Thank you guys for joining. We'll leave this up for a little bit.
Thank you, everybody. Really appreciate your time on a Saturday. Thank you.